Assalamualaikum and very good afternoon to everyone, and thank you for joining us at the live session from MAHSA University Sarjana Putra. I'm Umi Sarah and I will be moderating today's session. The title of this our webinar today is Radiation Safety Practice in Diagnostic Radiology, and it's hosted by Department of Medical Imaging, Faculty of Allied Health Science. So, dear viewers, radiation safety is the most important consideration that need to be focused in during medical imaging procedure, because many of medical imaging modality utilize radiation to produce an images. Thereof, ensuring the safety of both operator as well as the patient who are undergoing medical imaging procedure is the one of the most priority in medical imaging. To bring us to this radiation safety and diagnostic radiology session, the radiation protection, they got one philosophy, we call it ALARA, as low as reasonable achievable, thereby ensuring the safety of patient, radiographer, radiologist, healthcare worker that are work in the imaging room. We are fortunate to have with us our guest speaker who are specialized in the field of medical radiation to share with us on this area. But before I will introduce to our guest speaker, let me share some of the background regarding Faculty of Health Science and of the MAHSA University. We have three faculty. We have Department of Medical Imaging, we have Department of Environmental Health, and we have School of Physiotherapy. Okay. For Medical Imaging Department, we offer a program, Diploma in Medical Imaging and Bachelor of Medical Imaging. For Department of Environmental Health, we offer Diploma in Environmental Health, Bachelor of Environmental Health, Conventional Mode, and Open Distance Learning. And also we have a new diploma program, Occupational Safe and Health. For School of Physiotherapy, we have a diploma in physiotherapy, Bachelor of Physiotherapy, we have conventional and open distance learning, and also we have a master program or Master of Physiotherapy. So all our programs are accredited by the Malaysian Qualification Agency, or better known as MQA. We are also offer a program ODL. It's a great choice as a present moment that travel to somehow restricted, and please contact the faculty to the link provided or through our faculty Facebook page. Okay. So please visit our MAHSA website to know more about the program we offer, and leave a simple comment and we will get back to you. Okay. So I will introduce our guest speaker, Puan Siti Aisyah from University Science Malaysia. Let me give a brief introduction of her. Okay, Puan Siti Aisyah graduated with a health science first degree in medical radiation from USM in 2005, and she obtained her master in science in medical imaging from Curtin University in 2007. She started work as a medical imaging physicist in Hospital Ipoh, and now currently she is a lecturer in medical radiation program at the School of Health Science, USM now, and now Puan Aisyah is pursuing her PhD in biomedical engineering. Hi Puan Aisyah, how are you?
Hi. Thank you, Umi, for inviting me, and thank you, MAHSA, for inviting me to know about my knowledge and experiences about this radiation protection in diagnostic radiology.
Okay, so without further ado, I hand over the session to Puan Siti Aisyah. Okay, the screen is yours, Puan Siti Aisyah.
Okay, thank you very much. So today I'm going to present to you a little bit on radiation safety and measurements about what we've done in diagnostic radiology. As an introduction, the IAA safety standard reflects an international consensus on what constitutes as a high level of safety for protecting people and also the environment from harmful effect of ionizing radiation. This issued, which included the findings from the UNSCEAR or United Nations Scientific Committee on the Effects of Atomic Radiation and the International Commission on Radiological Protection, ICRP. The objective for my talk today is about radiation safety practices in diagnostic radiology, code of practice in diagnostic radiology radiation measurements, and radiation quantities related to stochastic and deterministic effect. Radiation safety practices in diagnostic radiologies, we have three exposures, which is occupational exposures, public exposures, and medical exposures. So all of these three exposures are considered as normal exposures that happens in the diagnostic radiology department, and they have the potential, they are the potential exposures that give the incidence and accidents exposures to all the personnel in the diagnostic radiology department. Public exposure include exposures to a person within a radiologic facility, including radiation penetrating the walls to the embryo and also the fetus of the pregnant workers. Medical exposures include patient exposure, biomedical research exposure, and also exposure to converters. In the whole world population, the annual effective dose per person from medical sources is 0.6 to
Hi, all our viewers. I'm so sorry regarding the internet distraction from our speaker. I think Aisha is having some technical issue and we will try to solve this problem. Okay. In Faculty of Allied Health Science, we are having three faculty. Okay, we have the Medical Imaging Faculty, the Medical Imaging Department, Department of Environmental Health, and School of Physiotherapy. So we are having different program, diploma and degree. We have a conventional mode and also open ODL program, open distance learning. We will try to contact Siti Aisyah. Sorry for the internet distraction from our speaker. I think Puan Aisyah is having some internet technical issue regarding their internet connection. We will try to solve this problem as soon as possible. I'm so sorry for the internet distraction again from our speaker. Okay, I think Puan Aisyah is having some technical issue and we will try to solve this problem as soon as possible. We'll recall back some of the information regarding our faculty. We have three departments. Um, uh, hmm, so today our topic is radiation safety practice in diagnostic radiology. It's the most important consideration that we need to uh, understand that exposure from the uh, radiation that coming from the imaging technique. Okay, so we have some radiation protection information. Okay, okay. We will still try. Sorry for the disruption, internet distraction from our speaker. I think Parsha is having some technical issue. Okay, we try to solve the problem as soon as possible. Um, Guys, I'm still. We are trying to still to try to resolve the problem. Okay, because Puan Aisyah is having technical issue and she's trying to solve uh, the problem. Okay. Let me. Uh, I try to recall some of the radiation protection. We have the ALARA concept, as low as reasonable achievable. This concept is important for we try to protect the operators to from the exposure. We have a time, distance, and shielding. Okay, we have time so that we are not being exposed too long to the exposure. This time we try to as far as possible from the exposure, and the shielding that we are giving to the radiographer or the patient that are inside the room is with to protect the operators from the exposure that coming from the X-ray tube. Okay, so this is the concept that we need to make sure it will be the important criteria for medical imaging. Okay, hi all the viewer. I'm so sorry that the internet connection with our guest speaker is still in progress. Okay, I hope Puan Aisyah will solve this issue. Okay, we will try to. Okay, let me brief back some information regarding the the our Faculty of Allied Health Science. We have the diploma program. Okay, we have the bachelor program. We have the this diploma program will have 3 years, and then it will cover for SPM student that want to join for 3 years, and then we have the bachelor program. We have a Bachelor of Medical Imaging, full-time and part-time, and we have also diploma entry program. Okay, and then this program are accredited with the NQA. Okay. Okay. If prospect in medical imaging is quite good, you can be a radiographer. You can be application specialist. You can go to the industrial radiography. Okay, basically you can join the government. Okay, for diploma you can join in a government hospital using SPA 8. Okay, and the U29 radiographer. Or if you have processed a Bachelor of Medical Imaging, you can process a U41 in a government hospital. Okay, so basically radiographer will have a lot of modality. Okay, we have a general X-ray machine. Okay, we have the fluoroscopy, we have the CT scan, we have the MRI, we have the ultrasound, memo, dental. There's a lot of modality in medical imaging field. Okay, for example, we are joining in medical imaging for the first year. You will learn quite basic equipment in year 1, general X-ray machine regarding the compartment, all the components, and then we learn about the X-ray tube. We learn about all the component that important, how the production of X-ray, how X-ray can penetrate to patient body and produce images. Okay, actually this webinar today, we will want the viewer to understand that even though the prospect as a radiographer seem like quite dangerous, we have their policy standard that will protect all the operator. Okay, so you are safe, and every year there will be a medical checkup for you to ensure the safety of the radiographer. Okay, and then now the current technology that all from most of the component is becoming changing to digital. Okay, so digital component is much more easy, very technical, and we have this artificial intelligence that coming up to put the revolution in medical imaging. Okay, and we have the fluoroscopy that our students, when they go to clinical posting, they will be exposed to this clinical area in the hospital so that they can um, learn how to do from simple procedure to the most complicated procedure. They will be assisted during the clinical practice. Okay. Um, they inside the program also we will expose our students for specialized equipment. For example, we have this memo, we have the dental, we have radionuclide imaging. That the field that after they graduate they can be specialized on it. Okay, they can be specialized in nuclear medicine. Okay, they can specialize to ultrasound. Or you can say for ultrasound they can be a sonographer. Okay, and this prospect in medical imaging is quite wide, and then it will give our student more exposure to different modalities in medical imaging field. Okay, all right. I'm not sure. Maybe Siti Aisyah still having a connection problem. I I need to still. Oh, all right. In radiation protection, basically, uh, we will teach the student regarding the three concepts as low as reasonable, achievable, the time, distance, and shielding. We will show the student the light apparent. We will bring the student to the simulation room, showing that how the radiation protection will be done in the lab. Okay, and then the radiographer will have their film badge that will detect the exposure during their working times. That's one of the components that will help to make sure the radiation safety for the operators. Okay, they have a lot of things that the student can be learned regarding radiation safety in diagnostic radiology. Okay. Hmm. Okay. For diploma program, basically for even though the student, let me recall back some of the program that we offer. So diploma in medical imaging, 3 years. Okay, first year they will be learn quite basic subject, anatomy, physics, okay, instrumentation, image processing, and then there are simple imaging procedure. And then in year 2, they will go to costing to cover some of the procedure that you learn in year 2. And year 3, they will learn in one semester, they will be going to uh, posted to clinical to go and experience the life of the radiographer in real condition. Okay, I think Puan Asha is ready now. Okay, I will hand over back the session to her. Thank you. dah boleh live. Okay, Puan Siti Aisyah still having internet connection issue. Okay, we will try to. I'm so sorry. We have her internet connection is very bad. Okay, we try to solve this problem as soon as possible. I'm so sorry for the problem. Okay. Um, okay. Before Puan Aisyah can resolve a problem regarding the internet issue, so I will come back to tell you regarding our program, bachelor program. It will be a 4-year program for direct entry from A level. Okay. Year 1, they will be learning some basic subject. Okay. Year 2, there will be some posting. Okay. And then they will go to the hospital and explain some of the procedure that you learn in year 1, and then they come back and then they learn all the basic theory of the um, component and modalities before they proceed to year 3. Okay, and year 3 they will start to having their proposal. They have their project for year 4. So we will guide the student to produce their own research project. Okay, we will guide them how to uh, produce research, and then in year 4 they will have their final project, and at the same time will go to their final clinical practice in year 4. That's the journey for the Bachelor of Medical Imaging. Uh, um, we still, I'm so sorry, we will still have internet distraction from our speaker. Uh,
Friends. Okay. So we look Okay, so the calculation of equivalent dose and effective dose is the most important calculation that we use in the department, where the effective dose will use the tissue weighting factors times the equivalent dose. So when the whole body is evenly exposed to 1 milligram of X-ray or gamma ray, so we can say that approximately the effective dose that imposed to the whole body is 1 millisievert. Okay, this comes because of the important organs that we calculate together, okay, to make it 1 millisievert. So when only the head is exposed to 1 milligram of gamma radiation or X-ray radiation, we only take into account the organ which is involved to absorbing the dose, which is thyroid, brain, salivary gland, and bone marrow, and also the skin. So the total calculation of these organs will become 0.07 millisievert. So the exposure limit is most importantly imposed by the NCRP and also ICRP. NCRP for occupational exposure, they limit the effective dose to 50 millisievert and ICRP limit to only 20 millisievert per year. The effective dose cumulative, NCRP is 10 millisievert times the age where the radiation is calculated, and also ICRP 100 millisievert in 5 years. Everything is the same between NCRP and ICRP, except that pregnant ICRP give a lower dose limit, only 2 millisievert compared to 5 millisievert for NCRP. Exposure to pregnant women, fetal dose from radiological, for example, like routine diagnostic CT examination in the pelvic region with and without contrast injection can lead to a fetal absorbed dose about 50 milligram. If a fetal dose is suspected to be high, like more than 10 milligram, it should be carefully determined by a medical physicist, and pregnant women should be informed about the possible risk. So same procedure should be applied in the case of inadvertent exposure or accidental exposure, which can be incurred by a woman later found to have been pregnant at the time of exposure or in the emergency situation. However, generally, we consider a fetal dose less than 100 milligram in most diagnostic procedure. The termination of the pregnancy is not justified, but they will give the risk because of radiation risk. Exposure to children, we need to optimize the process, especially in the case of CT protocol, which we use reduced MAS and also KVP, but not compromising the diagnostic quality of the images. So careful selection of slice width and pitch as well as scanning area should also be made. It is important that individual protocol based on the size of the child is used. This is derived by a medical physicist and the responsible specialist. Exposures to comforters of the patient, so dose to this person should be constrained, so it is unlikely that his or her dose would exceed 5 millisievert during the period of a patient diagnostic examination. Biomedical research exposures, there has no dose limit. Okay, because diagnostic radiological procedure may be part of biomedical research project. Typically, it means to quantify the changes in a given parameter under investigation or assessing the efficacy of a treatment under investigation. The basic safety standard require the use of those constraints on a case-by-case basis. In the process of applying optimization to exposure arising from biomedical research, the ethical committee would specify such dose constraint in granting its approval. For incident and accidental exposure, this exposure might incur when it is substantially greater than intended. Inadvertent exposure to the embryo or fetus in the course of performing the radiological procedure equipment. In case of software or system failure, accident, error, or mishap with the potential for causing a patient exposure substantially different from the intended, accidentally expose the wrong individual and also the wrong tissue. For occupational exposure, occupational exposure must establish by the room shielding prior to installation. And secondly, the classification of area and applying the local rules. This means that appropriate protective devices and monitoring equipment must be provided, properly used, and consequently that appropriate training made available to staff. For room shielding and layout, the design of radiation shielding for diagnostic installation should follow the NCRP report 147. When designing a shielding, assumption is made that the air kerma that we measure is equivalent to the effective dose. Radiation protection is characterized as whether weakly or strongly penetrating, depending on which dose equivalent is closer to its limiting value. So the lead equivalent thickness in millimeter that needed to be used is a minimum of 1.7 millimeter to maximum 70 kVp, 2 millimeter lead equivalent for maximum 100 kVp, and a minimum of 2.5 millimeter lead equivalent for maximum 150 kVp. So we need to also use 45 times 45 centimeter square apron with thickness of 0.5 millimeter lead equivalent for good gonad protection. So these are the approximate lead equivalent thickness of various material, assuming a broad beam condition where we expose using the maximum MAS and kVp. So the material that can be used, the equivalent to the lead thicknesses is brick, concrete, barium concrete, steel, gypsum, barium plaster, and plate glass. So the densities are different, and the thickness of the material can be calculated based on the energy that is imposed in the area. For the general radiography room layout, it is advisable to have 3 times 4 meters square of room size. Okay, that is the minimum room size. Okay, and it must have a door for the entrance of the patient, and also the control booth can be incorporated also in the room, and the door entrance must have also some safety standards, okay, to make sure that when exposure is made, the personnel is not accidentally exposed. All right. For the Siti room layout, a minimum of 8 meter times 4 meter square is advisable. Okay, that we can have a small unit of Siti and also a small control room adjacent to the Siti equipment. And LED glass is installed for the easiness of the operator, okay, to see the patient. And the service door must be lined with a 2 millimeter lead equivalent, and also a double door with a 2 millimeter lead equivalent. And also we can use brick, okay, approximately 9 inches thickness, okay, to protect from the scatter radiation. For interventional fluoro layout, so we can have a fluoroscopy machine to be installed in the middle of the room, okay, with a distance, okay, from the isocenter of the machine to the wall approximately 4 meters, okay, in between, right? So there must be a special passageway for the patient, and also a control room. Okay. And the wall of the examination room can be made by brick also with about 27 cm thickness. And you can also use a barium gypsum plaster, okay, to protect the room, and this can reduce the thickness of the brick. All right, classification of area and local rules. Here, the local rules mean the department rule that is applied for the areas and also must be abide by the workers, okay, in the diagnostic radiology department. So the area is classified into two areas, which is control area and supervised area. Control area is an area which a worker is liable to receive an effective dose of greater than 6 millisievert in a period of 6 months, or an equivalent dose greater than 1/3 of any relevant dose limit. So this is also an area when any person who enters must follow a specified system of work. All right. For supervised area, it is an area which a worker is liable to receive an effective dose of greater than 1 millisievert in a period of 6 months, or an equivalent dose greater than 1/10 of any relevant dose limit. And this is an area where it is necessary to keep the conditions of the area under review to determine whether it should be designated as a control area. Right. So now we look at the measurement in diagnostic radiology. Sorry. So the area monitoring that we can use, okay, are using the ionization chambers, proportional counter, and GM counter, depending on the type of radiation involved in a room. All right, for ionization chamber, number of primary ions or positive and negative charge collected is proportional to the energy deposited by the charged particle tracks in the detector volume, so that we can count the charge that is collected to give the amount of exposure. For proportional counters, it is more sensitive than ionization chambers and are suitable for measurements in low intensity radiation field. And the amount of charge collected from each interaction is proportional to the amount of energy deposited in the gas of the counter by the interaction. For GM counters, or all right, for gigamolar counters, they exhibit strong energy dependence at low photon energies and are not suitable to be used in pulse radiation fields, such as in normal general X-ray room, and particularly applicable for leak testing and detection of radioactive contamination. So GM counter is most suitable used in nuclear medicine. All right, looking at this diagram, so for area monitoring, we can do a scatter radiation measurement. Okay, so we have a label the point that we want to measure from A to F. Okay, let's say this is a normal general radiography room. So we have a control room over here and a supervised area over here. All right. So we measure the scatter radiation using the ionization chamber. okay, or the survey meter at these points. So this is for the control panel, and this is the door. Okay, and this is the adjacent to. To make the radiation survey, the dose we calculate correction factor for the survey meter. So okay, of
Hi all our viewer. I'm so sorry getting this internet distraction again from our speaker. I think she has have the same technical internet connection again. Okay. I hope she will have the internet connection back. And basically, she explained regarding the layout of the department that will have specification when we have a different modality inside the room. Okay, so when you put the machine in the middle, you need to make sure the exposure that will go through the room will not reach the outside. We have the supervised area, control area, and then they have their own dose measurement that will make sure this area is, we call it control area, supervised area. Only certain people can get inside the room. Okay, and then he will explain regarding the equipment that can detect the radiation, so that this equipment can be used as a QC component. Okay, for example, the QC, when we do licensing, we need to do QC to the machine. Okay, one of the component that we need to make sure is the scattered radiation. So we use this all the equipment to detect. We will put 1 meter and then expose the exposure that must be on the standard regulatory. Okay, so if more than that, or the machine is not produce some standard that being controlled by the regulatory standard, so the machine cannot be used to the patient. That is one of the component that we can prevent extra exposure to the patient. We were afraid that this exposure can affect stochastic and deterministic effect. Cases that cancer, okay, to the patient. So we have some rules and guidelines so that if the machine is not in proper condition, we will not use to the patient. Only the machine that have licensing from the KKM, Kementerian Kesihatan Malaysia, that can be used to the patient. That is I think the important key point, that this radiation safety in medical imaging will prevent accidental exposure or extra exposure to the patient. Okay, I think Siti Aisyah still having the issue. Okay, hopefully she can come back and proceed her lecture. We are so sorry regarding the technical issue from her side. Okay. I have catch some of the basic important key point at her presentation, so that I hope the viewer also can have some understanding regarding her presentation. Okay. Fine, Aisyah. Can proceed.
Yes. Yes, sorry, because the weather is not so good today. Yeah, it's like going to rain. Okay, we continue back at my slide about scatter radiation measurement. All right, we have different points, okay, in the most important area that we need to do radiation monitoring. So for example, we have a general X-ray room. Okay, so we have over here the X-ray room, the waiting room, and also the control room. And the most important is to check for the exposure, okay, at the lead glass, the side door, the main entrance, and also a lactation room, okay, which is opposite the X-ray room. So if we are using a survey meter model 451P, okay, by Fluke, okay, it's a US company. We can take measurements at that point, and then we calculate for the correction factor, okay, using this formula. And based on the range of exposure rate that is measured on each point, we can determine the response time and also the time constant for the survey meter. And then we calculate the true reading, okay, the milliröntgen per hour by product of measured reading and also the correction factor that we calculate earlier. And then we need to assume the workload, okay, to be about 150 exposure per week with 1 second per exposure to calculate the number of radiation which will imposed in that particular room. So by doing some calculation, okay, so we get the number of exposures in an hour per week, okay, for that particular points. Therefore, the total exposure per week can be calculated using the total exposure per week equals to the true reading times the total exposure per hour in a week. So a recommended Malaysian safety standard 838 year 2007 is the maximum permitted scattered radiation is must be less than 0.1 milligray, okay, or 10 milliröntgen per week. Next, the usage of personal dosimeter. All right, personal dosimeter, we can use different types, but mostly now we use film badge and also TLD badges. And some of us also wear different type of personal dosimeter, such as glass dosimeter or also OSL dosimeter. All right, for film badge, all right, film badge, they have a special emulsion photographic film in a light tight wrapper enclosed in a case or holder with windows with appropriate filters. Okay, these are the filters. So since the film is non-equivalent tissue, non-tissue equivalent, a filter must be used to flatten the energy response, especially at the lower photon beam quality, to approximate the response of a tissue equivalent material. For TLD batch, the most frequently used thermoluminescent dosimetry is the lithium fluoride titanium. Okay, and TLDs are convenient for monitoring doses to parts of the body, for example, the eyes, arm, wrist, or fingers. And used especially in the dosimetry of the extremities. Another type of personal dosimeter is a radio photoluminescent glass dosimeter. Okay, the material used is silver activated phosphate glass, and the dosimeter comes in a shape of a small glass rod. So the principle is when the silver is activated, okay, or exposed to the radiation, stable luminescent centers are created in the silver ion, producing one silver ion or two silver ions. So the readout technique uses pulse UV laser excitation. Okay. And a PMT will register the orange fluorescent emitted by the glass. And there are two types of RPL glass, which is high atomic number barium, which enhance low energy photon response, and the type with low atomic number lithium or aluminum phosphate, which is more tissue equivalent. And the advantage is that RPL dosimeter are easily read out and can be read out many times. Next, we have the OSL dosimeter, or optically stimulated luminescent dosimeter. So this is a high sensitivity, which is particularly suitable for individual monitoring in low radiation environment. The dosimeter can be used in a wide dose range up to 10 sievert in photon beams, and until from 5 keV to 40 MeV. All right. Direct reading personal dosimeter is also used, especially by the radiologists and also interventionalists, okay, in the operating theater and also fluoroscopy suite. So we have here the pocket dosimeters, the EPD, okay, electronic personal dosimeter. Okay, so for the pocket dosimeter is a self-reading pocket dosimeter that resembles like a pen, okay, and consists of ionization chamber, okay, ionization chamber that act as a capacitor. So the capacitor is fully charged and will read 0 before it is used. Okay, and exposure to the radiation in a period of time will produce the chamber discharging the capacitor, and the exposure, okay, is proportional to the discharge, okay, which can be directly read against a light, okay, through a built-in eyepiece. So you can look to read this dosimeter. You can look into this like a small window, so you can read the reading of the dose. Okay, for EPD, okay, it's based on miniature gigamolar counters or silicon detectors, and available with a measurement range down to 30 keV photon energy. Okay. All right, so operational quantity used for individual monitoring is personal dose equivalent, and it is measured at a depth or in millimeter unit in soft tissue. So the operational quantity of HP10, or we call it the 10 millimeter depth in soft tissue, result in an approximation of effective dose. Okay, for 0.07 depth, okay, it provides an approximate value for the equivalent dose to the skin, and 3 millimeter is used for equivalent dose to the lens of the eye. For strongly penetrating radiation, the depth D10 is used. For weakly penetrating radiation, such as beta emission, the ambient and directional dose equivalent is at D equals to 0.07 mm and can be used but are not likely to be encountered in the radiological environment. For individual dosimeters, it is either designed to estimate the effective dose or an equivalent dose to an organ, such as finger. So we can previously I explained to you about the TLD and also phlegm. So we can use that as an extremity dosimeter. And there are many types of individual dosimeters. So we have TLD, OSL, and other electronic devices. For the whole body dosimeter, I explained just now, we usually measure at 10 millimeter depth. And for certain area in the skin is at 0.07 millimeter. And how to wear the personal dosimeter, it is between the shoulder and the waist. And under any protective clothing such as the apron, the leg apron, whenever one is used. It is not on or outside the leg apron, but it should be used inside the leg apron. This is to measure the actual dose that is absorbed by the body. When the dose might be high, for example, for interventional radiology, we need two dosimeter. One we can use it under the apron at waist level, and one is over the apron at collar level. This is because we want to check for the absorbed dose at the thyroid level. All right, radiation quantities related to stochastic and deterministic effect. So we can categorize the effect of radiation based on deterministic effect and also stochastic effect. The deterministic effect is where there is a threshold or a level which effects begin to appear and it is known. For stochastic effect, no threshold is apparent and the probability for effect to appear may increase as the exposure level increases. So for example, deterministic effect can cause acute effects and also late effects. So both of these effects is categorized as somatic effects, where the effect is generally affecting the cells of different type of organs in the body except for reproductive cells. All right. For stochastic effect, it can have late effects and also hereditary effects. So this effect impose different syndrome and also risk. So I will explain to you after this. Biological effect per unit of absorbed dose will differ with the type of radiation and part of body exposed and is quantified by sievert. Low linear energy transfer, or we call it low LET radiation, such as photon, electrons, muons, is assigned as a radiation weighting factor of 1, whereas a high LET radiation, like neutron, protons of a particle, is assigned as radiation weighting factors between 5 and 20. This is because we depend on the energy of the particles. If cellular damage occurs and is not adequately repaired, the cell may not survive, reproduce, or perform its normal function. Alternatively, it may result in a viable but modified cell, which may go on to become a cancerous if it is a somatic cell, or lead to inherited diseases if it is a germ cell. The radiosensitivity related to the cell turnover rate, the white blood cells and the lymphocytes is the most sensitive cells, and the most resistive one is the brain or the nerve cells, or the brain itself. So effect of deterministic. Okay, we can compare between the acute radiation syndrome versus the sickness. Okay, for acute radiation syndrome, we have a subclinical level, okay, a hematopoietic, gastrointestinal, and central nervous system. Okay, the radiation sickness will take action at about this dose range. Okay, and it may become lethal. Okay, if the dose is more than 8 gray for GI cells. Okay, but for central nervous system cell, you cannot have any signs unless it is more than 30 grays. Okay, depending on the person body defense. Okay, acute radiation sickness in a prodromal phase. Okay, this sickness might incur to the patient or not. Okay, depending on their body resistive to the radiation. Okay, for 1 to 2 gray, okay, it is considered as mild. Okay, they can see some effects such as vomiting, diarrhea, headache, and also increase in body temperature. Okay, so if the dose is lethal, which is more than 8 gray, okay, the body might show a high fever in less than one hour. Okay, and also the patient might vomit in less than 10 minutes. All right. And some acute radiation sickness, which is shown in the latent phase. Okay, this is what we collect from the blood. Okay, to see the white blood cells. Okay, we have a different range of exposure from mild to lethal. Okay, so hair loss is actually experienced in a moderate level of exposure. Okay, more than 15 days post exposure. Okay, but if the dose is lethal, okay, we can have a complete hair loss less than 10 days. All right. Okay, cataracts. These are one of the most important effect of the non-stochastic, or we call it deterministic effect. Cataract induced by radiation tend to develop on the posterior surface of the lens, while the cataract associated with old age, diabetes, and etc. Also tend to occur on anterior surface of the eye lens. Posterior subcapsular cataracts can be induced by other causes such as trauma, and they might be appear as soon as 10 months after an acute exposure of 200 rads, about 2 gray, or chronic exposure of 1000 rad or 10 gray from a low LET radiation. Effect of stochastic, the primary cancer induced by radiation. Okay, we see that the LSS of the lifespan study done by to the survivors of Hiroshima and Nagasaki observed an excess in a wide range of cancer. So nevertheless, the overall increased risk is primarily due to excess of 4 types of cancer, which is leukemia, breast cancer, lung cancer, and cancer of the digestive system. For leukemia, okay, UNSCARE 2006 report estimate the risk of developing fatal case of radiation-induced leukemia at 2 dose range, okay, which is at about 0.1 sievert, okay, will give about 3 to 5 times 10 power negative 3 per sievert risk, okay, or 10 rams, right? 3 to 5 times 10 power negative 5 per rams, and at dose of 1 sievert, okay, will give about 6 to 10 times 10 power negative 3 per sievert and 100 rams. All right. These estimates have implicitly accounted for the DDREF. So DDREF is the dose and dose rate effectiveness factor, which is the magnitude of the risk over estimate at low doses taken as value 2, okay, for the low LET radiation. So RAM is the radiation equivalent man, okay. Usually the conversion is 100 RAM is equal to 100 rad to 1 sievert. All right, so you can calculate. All right, breast cancer. The BEIR is the Advisory Committee on Biological Effects of Ionizing Radiation. Okay, number 5 report estimated the excess risk at 0.7 times 10 negative 4 per rad, okay, which is about 0.7% per sievert, while the unscaled 88 report put the risk at 0.6% per sievert. Okay, lung cancer estimated at 1.9% per sievert, and for males, and for females it is 1.5% per sievert. Okay. So they both average the risk for male and female to be 1.5% per sievert. For GI tract cancer, ICRP 60 estimate the risk of fetal stomach cancer at 1.1% per sievert. The excess relative risk at 100 rem or 1 sievert is estimated at 0.23, and the corresponding relative risk is 1.2. For colon cancer, ICRP 60 estimate the excess risk at 0.85% per sievert. ICRP 60 estimate the risk for all components of digestive system to be 2.25% per sievert. So they also estimate that the risk for male is lower than the female, okay, but the average is about 2.3% per sievert. Next, the hereditary effect due to stochastic. So this hereditable effect could occur if the damage is passed on to subsequent generation. So there are a risk of germ cell mutation or the reproductive cells mutation for every 1 gray or 100 rats. The risk equation is calculated from studies done on mouse and analyzed with previous accidents caused by somatic stochastic effect that comes from Chernobyl, Nagasaki, and Hiroshima disasters. So the risk of having hereditary effect is increased by doubling the dose, which is the dose required to produce as many mutations as those that occur spontaneously in a generation. The MC said this is a disease class specific mutation component, and it is a measure of relative increase in disease frequency per unit relative in increase of mutation rate. And also the PRCF, which is the potential recoverability correction factor. This is the risk equation to bridge the gap between the rates of induced mutation in mice and the risk of inducible genetic disease in humans. So these are the work done by people to determine the risk per unit dose. ICRP 60 estimated the detriment for all generations to be about 0.5 times 10 power negative 4 per rem, which involved the dominant and X-linked mutation, which is believed to give 80% of this effect. The detriment for multifactorial effect is estimated at the same as the mutation above. So multifactorial effect have a genetic component but do not occur unless certain environmental condition exist. So therefore, we can have a total risk estimate for the general population is about 1 times 10 power negative 4 per rem. So when the ICRP took into account the years of life lost by the descendant, the risk will increase to 1.3 times 10 power negative 4 per rem. These are my references. Thank you very much for having your time with me, and I apologize for all the technical internet glitch that happens throughout my talk. Thank you very much.
Okay, thank you so much, Puan Siti Aisyah, for the informative presentation. We also so sorry to our viewer because of the technical issue that happened during the webinar session. Okay, we have some question. Okay, I got one question. Can we move to our QA and question and answer session? I got two questions. One question from Raja Fatiha. Can you explain about how we implement the 10-day rules and 28 days rule if the patient needs to undergo the radiation related procedure?
Okay, to implement the 10-day rules, okay, you should look at the last day of your period, okay, before you can implement the examination, okay. And another one, the 28-day rule is if there is no conception in during the 28 days of your cycle, okay, means you are safe to have the examination.
Okay, we have one more question for Nathan Reganathan. Okay, can you please explain correlation between MA and KBP on radiation exposure, comparing all the low voltage machine to the higher voltage newer machine that claim to be safer?
Okay, I would like to conclude my answer. Okay, if you want to optimize the examination, you should use lower MAS with high KVP, because lower MAS will give a lower dose, and higher KVP because we need to have a more penetrating power of X-ray photons to give a higher contrast to the image, and at the same time producing a good image quality. So it doesn't matter you're using the old machine or the new machine. It is the technique that you use. Usually we determine the quality and also the dose that will be imposed to the patient.
Okay, thank you for the answer. I think we have come to the end of the today webinars. Okay, I would like to thank to our guest speaker, Puan Siti Aisyah, for sharing your knowledge and experience that will give benefit to our audience. Okay, thank you for our audience that joined at the session. We look forward to your comments and your participation for future event hosted by Faculty of Science, MAHSA University. Please visit our website at mahsa.edu.my for more information, or leave your comment and we will get touch in with you. Please stay safe. Strict hand sanitizing and mask on. Okay. On behalf of MAHSA University, thank you for watching.
Thank you very much.
Thank you.